Thank you very much, Jennifer, for that introduction, and thank you very much for the opportunity to speak to everyone today and be part of the consortium rounds, and especially for the opportunity to tell you about the work that we've been doing here at Cancer Care Manitoba, which we call Moving Forward After Cancer Treatment. And I'm hoping that I'm only going to speak for about 30, 40 minutes at the most, and then we'll have lots of time for questions and discussion. I want to take this opportunity to just recognize the others who have been working along with me with this, oops, pushed too many buttons too quickly, sorry, with this work. In particular, many of you may know some of the names on the screen, but in particular, Dr. Jeff Sisler, who co-led this work with me initially, Donna Bell, who was our very competent project manager at the beginning, and now, as you can see, there's been some changes as this work has moved forward and as Dr. Sisler has moved on to a new position as Associate Dean in Family Medicine at the University of Manitoba. So we have a, just so that you have a sense that we have some leadership roles going on here at Cancer Care Manitoba for this work, and I'm continuing to co-lead it now with Dr. Joel Gingrich, who's the Medical Director of the Community Oncology Program. We have a steering committee, and then for each of the disease site groups in which we have implemented this work, we also have subcommittees, and within all those committees, we also have people who have lived the experience themselves of cancer, people with cancer themselves. I just wanted to give you a little bit of implementation context. Many of you may know this already, but we have 2 sites here at Cancer Care Manitoba in Winnipeg. One at the Health Sciences campus and one at the St. Boniface Hospital campus. We also have 17 rural community cancer programs throughout Manitoba, and we have about 7,500 new cancer diagnoses a year that are seen at Cancer Care Manitoba. Most of the chemotherapy is delivered in Winnipeg, but 25% of it is delivered outside of Winnipeg. Radiation therapy is only available in Winnipeg and in Brandon. So this work really, main goal is really to improve the experience of the person with cancer. We were fortunate to have some funding from the Canadian Partnership Against Cancer early on, which I'll tell you about. But basically, we came up with an idea of developing specific transitional appointments with written follow-up care plans that would be provided both to the patient and their significant other or support person, family member, if they desired, as well as to their primary care provider. We wanted to increase access to psychosocial and psychoeducational supports. We really wanted to support the discharge to primary care and improve communication at that discharge time, for lack of a better word, to primary care. And we wanted to educate primary care about survivorship issues. And we wanted to do all of this using our electronic health record, which is Varian or ARIA, that some of you across the country are also using, within a very busy tertiary clinic environment. So we wanted to do this within the cancer care environment. Why do we want to do this work? I know that I can't imagine that there isn't anyone listening to this talk who probably isn't aware of this as well. We know from over the years, and certainly I've known clinically for many, many years, and the research has shown this as well, that the experience of patients when they finish treatment is not necessarily or hasn't been a great experience for them. Often they feel cut adrift. We know that there are ongoing physical and psychosocial issues in survivorship. We know that patients often feel really unclear what to expect in follow-up, and they're very, very anxious about what they should or shouldn't be doing, or what their healthcare provider shouldn't be or should be doing in terms of their follow-up care. They need to know what they can take control of, what are the things about this experience that they have some control over in terms of being as well as they can be, being as healthy as they can be, and perhaps reducing risk of recurrence in the future. And we wanted to increase adherence to some of the follow-up testing because Dr. Sisler had done some baseline data, and some of the adherence to some of the follow-up testing, particularly in colorectal cancer, was not where we would like it to be. Cancer Care Manitoba is very committed to this work now. We've had funding both from the Canadian Partnership Against Cancer and more recently from our Cancer Care Manitoba Foundation. But we also have funding now from a project that's called In60 that I won't go into in too much detail, other than that there were some resources made available that allowed us to work on improving the patient experience as they leave Cancer Care Manitoba, making that a good experience for them, because we want to make room up front for all those new patients who need to be seen. And In60 is really about reducing the wait between when people have a suspicion of cancer and when they get their first treatment. And so we know that if we do a better job at one end, it's going to make a difference at the front end. As all of you know, this is having a good transition between active treatment to follow-up care is a part of the Accreditation Canada standards, and Cancer Care Manitoba has now committed to this work by providing a permanent project manager for us. We have completed this work with colorectal cancer, and I'm going to describe the work to you. I will get there, I promise. Throughout all of Manitoba now with our colorectal cancer patients, stage 2 and 3. We have also moved to working more closely with what we call our FPOs, our family physicians in oncology who work within the oncology center, as well as with our family physicians in our community cancer programs, and have involved them much more actively in the transition appointments and in this moving forward work. We're about to launch in our breast disease site group. We're very, very close to launching that. We've had approaches from other disease site groups to work with them, particularly lymphoma and ovarian, and they're kind of next in line. And we're also doing some work using the same model of developing a special transition appointment as well as resource materials for patients and families when patients are moving who have advanced cancer from anti-cancer treatment to palliative care. So we're kind of using that same model in the advanced cancer group. So if you're interested and we have time, I can tell you a bit more about that piece as well. So why did we decide to start with colorectal cancer? Well, primarily because this is the third most common cancer. We know that particularly people with rectal cancer really face significant changes in long and complex treatments and many consequences afterwards. And again, as I mentioned earlier, the adherence to CEA testing was around 22% and only 47% for CT scans in the previous 3 years before we implemented this work. So what is the intervention that I've kind of alluded to a little bit? So hopefully now I'll be able to tell you about it in a way that makes sense to you. So the first thing that we thought about is when should this work take place? When should this intervention take place? When should this transition appointment happen? And basically the timing has been determined by each disease site group. And so we work with the clinical team and really talk with them about what point makes sense in terms of your current practice, what point makes sense in terms of the trajectory of the illness and so forth. And with colorectal cancer, it was decided that after a clear CT scan, 1 year post diagnosis, the patient would be identified and prepared for the transition appointment. So we have done this slightly differently now than we did when we first started this work, as we learned along the way. So what happens now is that the patient at the time of that clear CT scan sees their oncologist, and the oncologist and the oncologist nurse then prepare them for the transition appointment, which will take place at their next appointment, usually about a month later. And at that transition appointment is actually done by the family physician in oncology or in rural Manitoba by the community cancer programs physician. And this was done partly out of just pure logistics in terms of time, that the FPOs and CCP physicians have a little bit more time than the oncologists seem to have in the clinic. And the other reason is because for many of these patients, particularly rural patients and even our urban patients, actually spend a lot of time with the FPOs as they go through treatment and really develop a very strong relationship there. And so we've moved to those physicians actually doing the transition appointment. What the transition appointment consists of is a screening for distress tool that, as we use and as many of you are using across the country, basically the revised ESAS and the Canadian problem checklist. The documents are prepared, which basically means that all the information that might be missing in the electronic chart is inputted around stage, diagnosis, what treatment the person had, and so on. And that results in a customized individual Part 1 of this survivorship care plan or follow-up care plan we call now. And so that customized individual patient plan provides all the history of that patient's particular cancer, their treatments, and then when their next test should happen, who should perform them, and all the follow-up care that would be helpful for both the primary care provider and the patient and family. So that is printed out of our electronic health record. So it pulls data from different places in the electronic health record, prints that out, and that same piece of paper is given to the patient as is faxed to the primary care provider, whether family physician or nurse practitioner. It also remains on the electronic chart so that any healthcare provider who has access to that chart can see that follow-up care plan. So this care plan has actually 3 parts to it. So I've just described Part 1, that is what we call the customized individual patient. So that is very, very customized, very individualized for that particular patient and what their cancer has been about medically and what to expect in terms of medical follow-up. Part 2 is a resource that we are developing for each particular disease site group. And basically, it is a resource, a written resource, that talks about the common issues and concerns that people finishing treatment for that particular type of cancer might experience. And then the resources that are available to them to help mitigate or help them cope with those particular long-term effects or short-term effects. And it's very, very specific to that particular cancer. This resource is developed by a working group, an interdisciplinary working group that would include dietitians, social workers, ostomy nurses, for instance, for the colorectal group, navigators, just about everyone you could think of, nurses, physicians, and so forth. And then, so that's developed specifically by that disease site group about that particular cancer and really focusing in on the unique survivorship issues that that particular cancer might be most prevalent for those particular patients. Part 3 is a resource that's a more general cancer survivorship information resource. Part 3 is posted on our Cancer Care Manitoba website, as is Part 2. But it also is a written document that is given to patients. And it basically covers the kinds of issues that most patients face in survivorship, like managing fear of recurrence, exercise and diet, back to work issues, relationships, and really, again, very specifically pointing people to the particular resources that we might have in Manitoba to help people with this. So that's part 2 and part 3. We then have some very specific post-treatment programs that were in existence prior to doing this moving forward after cancer work, but we've kind of enhanced them. Maybe that's a way to say it. And one of them, and again, I think there are several of you across the country who are familiar with cancer transitions as a program, and so we have been looking at that and have adapted it so that it's now an 8-week program, twice a week, and we've partnered with our Refit Center, which is basically our cardiac rehab center here in Winnipeg, and are moving towards more than just suggesting that patients attend this, really moving to more of a prescription or an automatic referral to that program when people have their transition appointment. Obviously, they always have the opportunity to decline if this is something they don't want to do, but very often, as you all know, rather than all of us have good intentions of making that phone call, joining that program, but if someone calls us up and makes that invitation, we're more likely to accept. And we also know that when healthcare providers, particularly physicians, recommend something in a prescriptive kind of way, the uptake is higher. So that's been an exciting new development for us that just happened in the fall of 2013, and we think is going to be a great enhancement. We've had really good uptake with it, and we're working through some of the organizational things to find ways to work together while respecting our Personal Health Information Act and allowing and promoting self-management and self-efficacy, but at the same time trying to make sure that people have the opportunities to take part in these kinds of programs. The other part of this intervention, of this moving forward after cancer, has really been to also ensure that the primary care community is comfortable and aware and meeting their education needs as well around how to manage cancer survivors once they have been returned to them for follow-up care. And so Dr. Sisler and the UPCON group and Donna Bell and others here at Cancer Care Manitoba have continued to provide these kinds of workshops to ensure that the primary care community is well prepared. So evaluation. So how do we know that this is making a difference, or how do we know that we're on track in terms of actually improving the patient experience? Well, one of the things that we did with the colorectal group was we did do a mail-out survey to a historical control cohort to find out about their experience prior to the intervention in terms of their finishing with Cancer Care Manitoba and their referral back to the community. And what we learned from that historical control was that basically patients were pretty well pleased, I guess, satisfied with their experience, other than younger patients and patients with rectal cancer. So those two subgroups appeared to have more difficulties, as one might expect, with that discharge back to the community. We're also aware that, you know, all of us kind of don't know what we don't know. So it's not that that historical cohort had any idea about what it might look like if it was done differently than their experience. But that was the results of that survey. We've also, when we did this work initially with help from the Canadian Partnership, did interviews and surveys with participants in those transition appointments early on. So we did some qualitative, and are kind of just finishing up the qualitative analysis of those interviews and surveys with the first participants, as well as did some, and that analysis is, as I say, just almost done. We did surveys with the family practitioners, and all of that was very positive. We did some satisfaction surveys with some of our moving forward sessions that we did prior to this kind of enhancement for cancer transitions, and that was good. We did some focus groups with clinic staff, and we've been doing some formative evaluation all along the way that you can kind of hear I'm talking about as we go. I can tell you a little bit more about the evaluation in a moment, but I'll tell you that the one-on-one interviews with the follow-up care plan recipients have been, are very, very rich. And, you know, when you read those transcripts, it kind of just makes you feel good for all the work that goes into this, to realize that, that at least through those interviews and qualitatively, it seems to be really quite a different experience. And just here's just one of the quotes that I'm hoping you can all read on your slides. I don't need to read it to you. Here's some more. We are very excited about the follow-up plan. The we, I think, is always an indication that these are things that patients are sharing with their family members as well, and that's coming through in the interviews. And it kind of gives you a little bit of everything. I think that some of the lessons learned and that were reaffirmed for us through this process was that practice change takes time, and it really takes resources. And so early on, when I was telling you that Cancer Care Manitoba has really committed to this work, and we now have a permanent position of a full-time project coordinator, project manager for this cancer transitions work, this is huge, because without that commitment and without that person for whom that is their one and only job, not one of many, many things that all of us do in many different ways, I don't think we would be moving forward as quickly as we are. And even then, it still is challenging in lots of ways. We really need engagement of the people for whom this affects the most. So not just the project manager and the project lead and the nursing leaders and obviously our IT team, but really significant commitment and engagement from the clinical teams. And as you may remember in my first slide, where we've set up these different teams. Yes, we have a steering committee that's kind of more of a senior leadership kind of group, but every disease site that we're working with, we have another working group, so that we're really working with the clinical team and patients for whom have had that particular kind of cancer, so that we can design this work within this clinical setting that is going to work within that clinical setting, so that we, as the barriers come up in those conversations, we find ways around them or recognize that what we can and can't do. And that's been really, really helpful. Ongoing on-site support and ongoing feedback is critical. So again, recently we've been doing some analysis of as although we've implemented this, really trying to audit, is this still really happening? Even though we implemented it, a year ago in X clinic, is it still really going on? And we are recognizing that we continue to need ongoing support, the little glitches that come up here and there. Some of our challenges and opportunities as we're moving forward, this is my last slide, really is again, I'm sure some of the same things that many of you across the country who are doing similar work are probably faced with, and I'm really excited to be able to talk with all of us together about how you are managing some of these challenges. One of the challenges is the costs of the Part 2 and Part 3 of this transition appointment, and the follow-up care plan. So as I mentioned, Part 2 is very specific to that particular cancer, and Part 3 is the more general one. So although we talked, we've kind of come, I feel like we go in circles around this issue all the time. So basically we know how expensive it is to produce physical paper copies of these resources. And we wonder whether they just end up, in the recycle bin, or whether people are really using them and referring to them. And so then we think about moving to a USB stick, or perhaps just a single page that says go to the Cancer Care Manitoba website and this is where you'll find these resources. But over and over again, as we kind of travel that circle of discussion, we get to a point where people, the clinic staff and others say it's just, given the target population, people like to have something in writing with them. And that's the feedback that we're getting in our qualitative study surveys as well from participants. But this is so costly, I'm just not sure how sustainable it is over the long term. So perhaps it's something that we're going to have to do in the short term, and as the world changes, maybe we will be providing these in more electronic form in the future. The other question is this an intervention for all disease site groups? And we think probably not, for a number of reasons. There are many disease site groups for whom the type of cancer and just that particular course of that particular kind of cancer perhaps doesn't lend itself well to the idea of transitioning back to primary care, in particular back to the community, and people are remaining within the cancer system. And we talk about how there's great value in having that transition appointment, even if people, and this does happen in our center as well, even if people are not going to be followed by primary care, but will continue to be followed for whatever reason by cancer care and the oncologist. But it is a slightly different process, and so it's always adjusting and readjusting and customizing by each disease site group. The ongoing audits and quality assurance is critical, and ensuring that we continue to do that. And then the evaluation. I know that the last time I saw you, Jennifer, when we were at the Kidney Cancer Forum and talking, had quite lively and stimulating discussion around evaluation tools when we're trying to measure this kind of work, and really trying to figure out what is it we're really trying to do, and what really is our objective, and really what is the best way to measure that so that we can, do the best that we can, really be effective, use our scarce resources wisely, and be making a difference in people's lives, and really improving the patient experience. And then finally, the other challenge and opportunity that we have is our electronic medical record, which has many, many things about it that are fabulous and work extremely well. And then there are other things about it, like all of you who work in electronic medical records, I'm sure know and have experience with, that just don't do what we would like it to do the way we want it to do it. And when we want to make changes to it, it is not a quick change. It seems to be a very slow process, and there are so many competing demands to make changes within the electronic medical record that sometimes can be challenging. At the same time, the fact that we can even print the kind of follow-up care plan that we are able to print out of area is really, really exciting and has been helpful all around. So, I do feel a bit like I'm talking into the abyss, as you can imagine, and any of you who've given these kind of presentations perhaps feel as well. That was my last slide, I'm sure. And I'm hoping that you heard me and that I was clear with what I was trying to get across, but I'm very interested in comments and questions at this point.